Welcome to the FlightBridgeED Podcast series.
Hey folks, Eric back with you. I want to first say that I apologize for the delay in the podcast lately. We've just been so inundated with review class requests. We've been traveling all over the country. So I guess that's a good thing, but it doesn't allow me a lot of extra time to record the podcast, so I apologize. Today we're going to continue with the Nightmare series that we've done and started over the last 3 or 4 months. It's been very, very successful, and I just want to say thank you for all the kind emails, all the nice wishes that everybody sends us on a weekly basis. We really feel empowered by the nice comments, and it just makes us want to do better things and bring new ideas and new concepts out to the critical care arena regarding pre-hospital EMS, emergency and ICU related to hospital staff, RNs, and flight crews, flight nurses, and flight paramedics around the country. So we really are nothing without you. We realize that, and we want to continue to do a great job. Today we're going to continue, like I said, with a case study series, The Nightmare Patient. This case study is a little bit different. We're going to do a pretty quick case study. It's going to probably be a 15-minute podcast, and then that's going to lead us into the next podcast that we'll do in a couple weeks, and we'll look at intra-aortic balloon pump therapy and the pathophysiology related to that. We'll go into the different waveforms. If you haven't noticed the last podcast, we actually switched that to the enhanced podcast, where you can actually download that and see pictures related to the podcast, whether it be waveforms or anything I'm talking about will actually pop up on your phone or your screen when you're listening to it. So if you haven't checked that out on our website. Go to the last podcast series that we did on advanced hemodynamics, and you can check out the enhanced version. Okay, so for the case report, we have a 65-year-old African-American woman. She's got a long history of COPD that's uncontrolled. She doesn't really take care of herself very well. She's got a pretty extensive medical history. I believe she had hypertension that was uncontrolled. She did have breast cancer, and she was in remission for that. And she had 2 pulmonary embolisms in the past 5 years. She's been a 4-pack a day smoker for 30 years, so that's pretty extensive. And she presents in the ER quite often for exacerbation of her COPD. On this presentation, she arrived at a smaller ER, and she was in full exacerbation. She was extremely fatigued. She had very little air movement. When the flight crew got on scene, they listened to lung sounds, and her chest was almost silent. They continued nebulizer treatments, beta-2 agonist, of course, albuterol. She'd been given Atrovent. They were even considering at that point going to mag sulfate and trying that. And, at this point, we have to make the decision, is this patient a candidate for intubation? And if you've heard my other podcasts, kind of the way we deal with asthma, COPD, exacerbation is a little bit different than yesteryear. We've never wanted to really intubate these patients. We've never wanted to put these patients on the ventilator and keep them on the ventilator because it's very, very difficult to get them off. Once these patients have fatigue, and then you start putting them on the ventilator, they have extreme atrophy of those respiratory muscles, and it's very hard to get them firing again. So the way most level 1 facilities, I should say, take care of asthma or COPD exacerbation is they will maintain them as long as they can. So basically right before they become obtunded, that's when they're going to make the clinical decision to intubate the patient. Other than that, they're going to try everything in their power, every medication, everything to prevent this patient from being intubated. Now we got to remember we have different tools. We can use BiPAP now. We can use CPAP now. BiPAP is going to be the preferred method as far as opening those airways and allowing a bi-level mode of ventilation, so they can exhale much easier on the exhalation phase. And we know when we set up BiPAP, we want our IPAP to, let's say, be 15. We want our EPAP to be very, very low. And the EPAP is your PEEP setting on your ventilator. So you would want your EPAP to maybe be 2. So you want that gradient between your IPAP and your EPAP to be very, very large. On a patient that maybe would have an oxygenation failure, you would want that gradient to get closer. So your PEEP would actually be higher. So let's say you would have a 15 and 8. That gradient gets closer together, and that's how we would deal with a patient that would have an oxygenation failure like pulmonary edema. But remember, with a COPD patient like this, we have a presentation of ventilation failure. This is a strict ventilation failure. She can't maintain proper CO2 levels. We know COPD patients have poor CO2 receptors in their medulla, the respiratory centers in their brain, and so they live at a very hypercapnic state. The interesting thing about this presentation is once the flight crew got the patient up, packaged, got her up in the air, they had about an hour flight to a level 1 facility. During that hour flight, they noticed the patient's respiratory distress becoming more severe, and she started complaining of severe substernal chest pressure that radiated into her left shoulder. They did a 12 lead, and the 12 lead showed anterior ST elevation in V3 and V4. As anybody would, they started treating this patient for that MI. Shortly after the presentation and shortly after the 12 lead, they noticed the patient's blood pressure dropping, and she became bradycardic. At this point, they identified the patient was in cardiogenic shock, and it's not uncommon for patients to have an anterior MI to present with cardiogenic shock. I've had that happen many, many times, and oftentimes the etiology behind that is they have what's called a papillary muscle rupture, and that papillary muscle is located behind the valves. They control the opening and closing of the valves. So, for instance, on a left-sided cardiogenic shock or a left-sided failure like that, if you have a papillary muscle rupture, your patient can have pulmonary edema, flash pulmonary edema, and this can be at different levels. You may have just a mild case of pulmonary edema, and it could be flash where the patient is actually spitting out fluid. Obviously, in those circumstances, aggressive airway management is going to be the primary goal. So the flight crew came up against a pretty sick lady. Not only was she a COPD exasperation, her end-tidal CO2s were approximately 70 to 72. She also went into a cardiac presentation, I should say, and that presentation led into a cardiogenic shock. They did everything they should have. They identified really quickly the MI, and then she became hypotensive and bradycardic. So in that situation, that's kind of where we're at right here. What causes this? Obviously, when you're in flight or you're actually in the back of an ambulance, there's no real understanding of what causes. We just know this is a cardiogenic shock. So how are we going to treat this? Well, are we going to want to give atropine? Well, I say absolutely not. Our heart does things for a reason. Our heart slows down for a reason. It's slowing down because the oxygen efficiency of the heart has been depleted significantly. There's some type of a problem there, and so the heart needs to slow down because of that. So atropine, for me, is one of those medications that I find to be overused. This is, again, my opinion, and I remember it only works for any heart arrhythmia or any heart rhythm above the AV node. If you have any heart blocks, if you have a third-degree block, if you have anything junctional, your atropine's not going to work at all. So, why give it? So that's where I think you have to look and think outside the box. Think critically. Don't be a cookbook clinician. Don't just because the protocol says, well, symptomatic bradycardia, we're going to give atropine. Don't just give atropine. You need to think about what's going on, and we have something called a pacer. For this lady, pacing her is going to be the best option. We want to pace her at a rate of 70 to 80. We want to make sure that we give her a little bit of sedation, right? Your blood pressure is already low, so if you have the ability to give her ketamine, ketamine is going to be a great medication for multiple reasons. Number one, she's already got bronchial constriction, so we know ketamine is a medication that causes really good bronchodilation. It also is very stable on a patient that's hemodynamically unstable like she is. It's got analgesic effects, and it's got sedative effects. So it does 3 or 4 things here that will really benefit this patient. At this point, they identify that she needs to be paced. They pace her. They give her a rate of 80. They turn up the milliamps to approximately 50. They get good mechanical and electrical capture. Remember, you have to have both. You have to have pacer spikes that match a pulse, and the best place to always feel that is going to be your femoral pulse. So they identify that they've got good capture, and just based on the paced rhythm, they do see an increase in heart rate, and they have a systolic blood pressure in the 82 to 84 range, and their MAP pressure is hovering around 60, 55 to 60. They arrive at the receiving facility. They transfer the patient and get report. Follow-up, they identify that this patient has a phenomenon called Takotsubo's apical ballooning syndrome. All right, so that's what this case presentation is all about. If you're sitting listening to this and you're like, what the heck is that? I'll explain it. This is a new discovery, and I say new discovery because when we look at the evolution of medicine has been around a long, long time. When we identify a phenomenon like this, and this has been in the last 20 years, I think that that's a pretty cool thing. That's something that we've discovered in a very progressive environment when there's a lot of research going on. So Takotsubo's apical ballooning syndrome was discovered by the Japanese in 1991, and they identified in multiple patients that with a massive stress response, whether it be anxiety, whether it be losing a loved one, whether it be losing a dog, whether it be a septic patient that was in the ICU and was been given multiple catecholamine medications for pressor augmentation, these patients have had a phenomenon called apical ballooning syndrome. And essentially what this is it's caused from a massive release of catecholamines that weakens that left ventricle. It causes the apex of the left ventricle to balloon out. And that's where the word Takotsubo has come from. Takotsubo is a vase that they use in Japan to put the octopus in that they catch in the ocean, and they eat. And so they store them in those vases, and those vases are called Takotsubo. That's why they named it that. If you look at an echo, and we're going to place a picture in the presentation, in the enhanced podcast presentation, illustrating this, you'll see that apex looks like a massive, round, perfectly round vase. So what do we do in this situation? Well, one thing to remember is this happens in a very high population of women, approximately 80%. So only 20% of men have this phenomenon. Whether that's because men can handle, because of their body surface area, they can handle maybe a larger release of catecholamines. They're used to having a larger release of catecholamines. I don't know. I don't really know the science behind that. That's what I would kind of bet in that circumstance. Oftentimes, Takotsubo's apical ballooning syndrome presents with a MI presentation. They'll have an MI, and they'll actually have anterior septal changes on their 12 lead. And so, we look at this, we treat this like an ST elevation MI. We put these patients in a cath alert, and these patients oftentimes will go in. They'll have a perfect cath. They'll go in, they'll identify that there's no coronary artery occlusions, but this patient is still profoundly sick, still profoundly in a cardiogenic shock presentation. At this point, they'll do an echo, and via an echo, they can identify and take a picture of this and look and see that this is apical ballooning syndrome. So how do we treat this? Well, with this patient, they did a little bit of history, and they identified that this patient had this phenomenon once previous a few years back, and it wasn't caught. The physicians got to talking, the pulmonologist, the cardiologists that have treated her over the last few years. You got to remember, she's had 2 pulmonary embolisms. She's an uncontrolled COPD patient that still smokes excessively. So they started talking. They identified that she had a phenomenon like this a few years back, and it resolved on its own. So that's the thing. These cases will either present very, very extreme like her. She was in a COPD exacerbation. She was probably having a massive catecholamine release because she was so fatigued. Every receptor in her body was releasing catecholamines, epi, norepi, to try to stimulate something. Her heart rate was very tachycardic, and so just that stress response caused that weakening of that apex of the left ventricle. So in this situation, how do we treat this? Well, we're just going to do supportive care, and that's really the big thing. So most patients with this presentation are going to be perfectly fine with normal watching the patient. Most of these patients present where they can manage themselves. They'll be placed in the ICU or CCU, and they'll be watched. They don't need to be intubated. They just need rest. The heart, once it comes back to normal, once the catecholamine levels in their body come back to normal, the heart will actually go back to its normal state. It'll actually fix itself. There are those circumstances, though, that these phenomenons are so aggressive, so taxing on that heart, that these patients need to have a balloon pump placed. When these patients have to have the balloon pump placed, it's basically to augment that left ventricle. That left ventricle is so taxed and so weak from the catecholamine release. They'll place this balloon pump. They'll put on a 1 to 2, 1 to 1, 1 to 2, depending on how sick that heart is. These patients will probably be intubated at that point. Put on BiPAP or CPAP, and that balloon pump is going to do all the work. And then as the heart becomes better, they're going to slowly decrease augmentation and go from a 1 to 1 timing to a 1 to 3 timing, and they'll slowly let that heart regain its normal function. Like I said, most people in this situation present perfectly fine. They actually will resolve their symptoms on their own. If you remember back in the podcast, I said that this is also called the broken heart syndrome. A lot of times this happens in relation to some huge traumatic event, and a lot of people that I've talked to about this, discussed with different nurses that have seen this in the ICU, it's been associated with some type of traumatic event, loss of a loved one. I talked to one RN that said that it was a loss of a loved one and her dog in the same week, and that just caused such a stress in her life. It caused a huge catecholamine release, and she suffered from a severe cardiogenic shock secondary to this apical ballooning syndrome. So at this point, we're going to kind of stop. Again, remember, we're just treating the symptoms. This patient was a COPD exasperation. The flight crew did very, very well as far as managing this patient. They placed this patient on BiPAP. Like I said, you want to make sure that gradient is very wide. So your IPAP on BiPAP is your ventilation side. Your PEEP or your EPAP is going to be your oxygenation side. And remember, a COPD patient is not an oxygenation failure. The only reason why they may have a low PO2 is secondary to a low minute ventilation. That low minute ventilation or low tidal volume is because of poor compliance. So if you fix the ventilation side and you allow that patient to relax and rest, everything else will take care of itself. That's all I have for this presentation. I do want to bring up that we're going to do a kind of a spring blitz. We're going to offer our package deal on both of our books at a discounted rate, so look for the newsletter to come out and explain that. We've added multiple classes to our website. We're doing a class in Casper, Wyoming, I believe June 5th and 6th. We're doing another class in Tulsa, Oklahoma, June 21st, 22nd. We're doing a ventilation and oxygenation physiology class in Brookings, Oregon on the coast. If you want to come visit us there, we're doing an 8-hour intensive ventilator management using LTV 1000s and 1200s. And then we've got another class set for Alabama, Rainsville, Alabama in August. And then last but not least, we have another class in the LA area, actually Rancho Cucamonga, and that's about a 40-minute drive from Los Angeles, and that's going to be in September. If you have any questions, you want to reach out to me, you need help with your FPC or your CFR and exam, please don't ever hesitate to email me, eric@flightbridgeed.com. Remember, we do have our practice exams on our website. I believe that is one of the best tools that we have in preparing you to take these exams. I think it's an affordable price for what you get, $79.99 for 3 timed attempts. You get the rationale after every exam on what questions you missed and what questions you got correct. On behalf of everybody here at the FlightBridgeED team, we want to thank you, and we'll talk to you soon. Thanks. We want to thank you for following FlightBridgeED.